You are so warmly welcome to this medical education session. This is your first time doing it today. You are especially welcome. Medical, we're really passionate about making medical education radically accessible for every healthcare useful for your practice. Before we go any further, it's important that we share our disclosures with you, and I'm just going to bring those up on your screens just now. In today's session, we are going to be learning how to apply current cholesterol management guidelines, including LDL-C targets, adherence strategies, and treatment escalation approaches. And we're going to learn how to design strategies to overcome clinical inertia and streamline access to guideline-recommended lipid-lowering therapies for different patient profiles. And we're going to be using the latest evidence and guidelines to help us to do that. But before we do our education today, what I'd love to know is where you're currently at in your educational journey. And we like to do that using some polls before we get going. And we also like to do it around some patient cases. So what I'm going to do is bring up some polls just on your screen just now. And I would love to hear your thoughts on these polls before we dive into today's session. So the first poll is this. According to the CTT meta-analysis data on the side effects of statins, what is the appropriate risk of developing new onset diabetes for patients on high intensity statin therapy compared to placebo? If you let us know what you think, A, B, C, D, or E, you can pop your answer into that chat. Super, that's great. Thanks, everyone. Super. Thanks, everybody. Okay, great. And the second poll is this. According to the 2025 European Society of Cardiology, European Atherosclerotic Society guidelines, what is the recommended LDL-C treatment goal for a patient classified as being at very high risk for cardiovascular events? A, B, C, D, or E? If you could share your thoughts in that poll, that would be super. And if you're just joining us, it is really great to have you here. We're doing some polls. You'll find them in the chat box on the right-hand side of your screen. If you're joining on mobile, you will find them by clicking the little chat icon at the bottom of your screen as well. Okay, and what I'd love to do is to hear your thoughts on a few cases. So here are some cases. The first case is this. A 67-year-old male with a history of myocardial infarction 5 years ago presents for follow-up. He has a documented history of severe myalgias with both high-intensity atorvastatin, more recently non-daily rosuvastatin, 2.5 milligrams 3 times weekly. He's currently on ezetimibe, 10 milligrams daily, but his LDL-C remains at 125 and well above his goal of less than 70. What is the most appropriate next step for this patient? A, B, C, D, or E? If you can share your thoughts, that would be super. How would you manage this patient? And if you don't know the answer, don't worry. We're going to be covering each of these topics in our session today. So if you don't know now, hopefully by the end, you will. So don't worry if you don't know the answer. And you can answer anything that you've missed by scrolling up in the chat box on the right-hand side of your screen. Okay, the next case is this. A 52-year-old female is referred for primary prevention. Her 10-year ASCVD risk score is 6%, but she is hesitant to start statin therapy due to fear of side effects and a belief that she doesn't need medication. She expresses a desire to better understand her true risk. Which of the following would be the most appropriate tool to utilize in this situation? A, B, C, D, or E? If you can share your thoughts, that would be super. Okay, thanks everybody. Great, super. If you're just joining us, we're doing some polls, and we'd love to hear your thoughts on how you would manage each of these patients. Okay, great. Thanks everybody. Okay. Penultimate case. is this. A 62-year-old patient reports diffuse myalgias after being on atorvastatin 4 milligrams for 3 months. He has previously tried simvastatin 40 milligrams with similar symptoms. His ASCVD risk is high and his LDL-C remains at 130. Which of the following is the next best management option to propose? A, B, C, D, or E? If you could share your thoughts, that would be super. Okay, thanks everybody. Getting lots of good answers here, which is great. And then we're going to move on to our final case for today before we dive into our education. I'll just give you a few seconds on that last one. There's a little bit of reading. Okay, super. Thanks, everybody. Okay, last case for today is this. A 65-year-old male with established coronary artery disease is on maximally tolerated atorvastatin. His LDL-C remains elevated at 95. You're discussing treatment intensification, and the patient asks if any therapies can actually reverse the plaque buildup in his artery. Based on the Glagov trial, which you can tell him, what can you tell him regarding the addition of a PCSK9 inhibitor? A, B, C, D, or E? If you can share your answers, that would be super. Okay, great. Thanks, everybody. Lots of interesting answers here, which is good. And if you don't know the answer, don't worry. We're going to cover this in our session today, so it will hopefully all become clear. And if you have missed a poll, don't worry. You can scroll up and you can see them all on the right-hand side of your screen. Hopefully, they help to begin to get you thinking about what we're going to be learning about today. And I just want to ask you 2 final questions before we start. And this is just about how confident you currently feel. How confident are you in applying current cholesterol management guidelines, including LDL-C targets, adherence strategies, and treatment escalation approaches for your patients? 1, not confident at all, right up to 5, extremely confident. How confident do you feel? Okay, super. Thanks, everyone. That's hopefully a quick one to answer. And then the final poll for today is this. How confident are you in designing strategies to overcome clinical inertia and streamline access to guideline-recommended lipid-lowering therapies for different patient profiles? 1, not confident at all, right up to 5, extremely confident. Super. Thanks, everybody. Okay, we're going to dive into our education today. And covering the topics that we're going to be discussing today, we are really honored to have Professor Chris Cannon. And Professor Cannon is Professor of Medicine at Harvard Medical School. He's a senior physician in the cardiovascular division at Brigham and Women's Hospital. I'm going to hand straight over to Professor Cannon.
Hello, I'm Chris Cannon, and I'm delighted to review with you lots of data on optimizing LDL control. I'll begin with disclosures, and these are the various companies I've done research with, or other research groups that I'm part of have done research with. For the learning objectives that I'll try to cover, we'll begin with trying to apply current cholesterol management guidelines, focusing on LDL-C targets, but talking also about adherence strategies and treatment escalation approaches, and incorporate all the latest trial evidence to support that with the various different agents that we have. And then I'll also try and talk about how we can design strategies to overcome clinical inertia and really streamline access to these guideline recommended lipid-lowering therapies for different patient profiles. And this is, both of these are a struggle to meet the guidelines and actually make it happen patient by patient. So I'll begin with the 2018, which are the current ACC-AHA guidelines. They're due for an update next year. And these guidelines begin with, this is the focus on secondary prevention of patients with documented atherosclerotic cardiovascular disease, where they divide patients into very high risk, which is a series of other additional risk factors, or polyvascular disease, those with diabetes or CKD, or other patients with ASCVD who are not at very high risk. And on the right, we have very good evidence supporting high intensity statin. Then if the LDL is above 70, still to add ezetimibe. And then if it's still above 70, to add a PCSK9 inhibitor. And in some cases could go straight from high intensity statin to PCSK9 inhibitor as another approach. For the less high risk patients, these guidelines split by age, although probably unnecessarily, and speak of just a high intensity statin and ezetimibe, and less so of PCSK9 inhibitor. At the time, there weren't as many trials in that population. Now, the ESC guidelines have actually been updated this year and take a pretty thoughtful approach where the higher the risk, the lower the LDL target. And this makes perfect sense. It's very evidence-based. I'll review with you a lot of the trials that show this. The nomenclature is slightly different. The low and moderate risk are really the primary prevention patients, and then the high-risk patients, either by these various factors here with other risk factors are shown. They recommend a goal of less than 70, whereas anyone that they call very high risk is any evidence of atherosclerotic cardiovascular disease, especially if you also have, diabetes or chronic kidney disease or FH, familial hypercholesterolemia. They've added a new category in these guidelines of extreme risk, which are patients with ASCVD who experience a recurrent event while taking their maximally tolerated statin, or patients with polyvascular disease, so disease in, say, the coronary bed and also peripheral arterial disease or cerebrovascular, where the goals for the very high risk is less than 55 milligrams per deciliter and less than 1.4 millimoles per liter, and then less than 40 or less than 1 millimole for the extreme risk group. And we have very good evidence for the very high-risk group in multiple trials, as I'll show you. Then it makes perfect sense if patients are breaking through to push them even lower on the LDL. So the great news is that we have a whole host of therapies that can do this. And this was a slide I put together, I think, a year ago, speaking of the 50 years of trials. And I suppose if we start from diet, it's 55 years now of different interventions to lower cholesterol and the benefit that's seen. So using diet is, of course, where we always start. Cholestyramine, a bile acid sequestrant agent. Ileal bypass was tested, but then statins or high-dose statins. Fibrates and niacin had been targeted a little bit more towards HDL and triglycerides and had only mild LDL reduction and non-significantly mildly lower clinical events. But then ezetimibe, PCSK9 inhibitors, CETP inhibitors are still investigational, and bempedoic acid all have been shown to reduce LDL and reduce clinical events. So a whole host, and there's even more coming. So really exciting new versions of these classes coming that will have many different ways to try and get patients to those goals that the ESC guideline has nicely highlighted. So I always start with the cholesterol treatment trial lists slide of the effect of statins, and they've normalized this for every millimole reduction, or about 40 points in LDL, that you can see a significant reduction in non-fatal MI, coronary heart disease death, need for CABG or angioplasty or any revasc, ischemic stroke, or any combination of those different vascular events. About a 22% reduction in those events for each millimole of LDL reduction. So one of the newer areas that I think is being incorporated into statin treatment I wanted to share is that there is a risk. We all know of the risk of muscle aches. Some people think they have muscle aches, but some do. And so we have to work to find a tolerated dose, and sometimes patients can't tolerate a statin. But the risk of new onset diabetes is one that I think people are realizing is an important factor for some. I find it more in the primary prevention, but where dose-dependent effect is seen. So the low to moderate intensity statin have a very small increase in the risk of new onset diabetes. The biochemically determined would be an increase in the hemoglobin A1C to meet a risk of diabetes, about 10% higher risk of that. But the high intensity statin, it's more like a 35% increase, the bottom line there. And so sometimes if people have pre-diabetes, they would be pushed more rapidly towards diabetes on a high intensity statin. So in some of those patients will use a low intensity statin, lower moderate, and then start adding the non-statin agents, none of which have any effect on diabetes. So that's one nuance on statin treatment, I think, in current practice. So moving on to some of the evidence that supports the targets that the ESC guidelines have. This was one of the first lipid studies I was involved with now 20 years ago, where we targeted a lower LDL. So at the time, the guidelines said get less than 100, and we said, well, let's try and get less than 75 is what we had said in our protocol. And we got to 62 on average. And as shown on the right, the more intensive statin regimen that got the LDL down lower had a lower risk of cardiovascular events. And so that was the first randomized trial of two different strategies that, lower is better for the LDL. This is another way of looking at that concept where you plot out the placebo or the statin or the high intensity statin event rates versus the LDL that they achieved. And you can see the lower the LDL is, the lower the risk of cardiovascular events. And each pair of those dots are randomized, but overall this is more of an observational look, but one that we'll see time and again that the lower we push the LDL, the lower the event rates. So knowing that intensive statin getting to LDL of 70 looks like it's helpful, we asked the question of, well, should we stop there or should we push lower? And so in this study, we added a second agent, ezetimibe, got the LDL down to about 54 compared to just under 70. And as shown on the right, we did see a further reduction in clinical events. And so even lower was even better with the addition of another agent. Now, this was also a non-statin agent, and so people wondered, well, is it as good as the statins that have been seen in so many trials to be beneficial? And so this is a plot that the cholesterol treatment trialists did, all the purple ones, and we plotted on top of it where the ezetimibe effect would be. And you can see that the clinical benefit relates directly to how much LDL cholesterol reduction there is. And the IMPROVE-IT data fall exactly on that regression line, meaning that the amount of relates to how much change in LDL, regardless of whether it was a statin or ezetimibe. And I think I have other slides that's been shown with the other non-statin agents as well in subsequent trials. So the key is it's the LDL reduction and less so of how you get the LDL reduction. So the PCSK9 inhibitors are very potent agents. So these, as you can see on the left, will lower the LDL about 60% and can get the LDL to super low levels. In this case, 36.5 for the average LDL in the study. And this study was one that looked at the plaque in the arteries to see whether one could get regression in the size of the plaque. And as shown on the right, when you add the PCSK9 inhibitor on top of statin, that you can get a reduction in the size of the overall plaque volume. Now, interestingly, they went on to plot out the achieved LDL in the different patients and whether the plaque volume got bigger or smaller when they compared baseline to a year and a half later. And you can see that that lower is better mantra is here now with the plaque, that the lower the LDL, the more likely you could get regression in the size of the plaque. And conversely, if you left the LDL up at 100 or so, the plaques would tend to get larger over time. I actually draw this exact graph for patients to help explain to them if we see evidence of coronary disease or they've had an MI, that we want to get the LDL below 70 to try and get the cholesterol out of the arteries and shrink those plaque size. I also have this diagram, although a different color scheme than the design here, to illustrate what a normal vessel is, what one in the middle has a vulnerable plaque, and then the effect of getting the LDL very low down. You can see in the middle a large lipid pool, which is all the cholesterol built up in there, and then there's a fibrotic cap on top. A very thin one. So I explained that the problem is if more cholesterol keeps getting in, that cap may break if there are other, stresses and, high blood pressure or what have you. And that's what causes an MI, a rupture of a vulnerable plaque. If we can get the LDL below 70, and the lower the better, the cholesterol starts coming out of this plaque, and it's replaced with fibrotic tissue so that cap is very thick, and that plaque on the right is never going to break open because it's got that thick coating that would prevent any rupture of that structure. And so sharing that with the patient to have them see what we're trying to do with the cholesterol lowering, I've found to be very helpful, and patients really do like understanding what we're trying to do. So for the PCSK9 inhibitors, one of the several trials for clinical events is shown here. Again, a big LDL reduction. And again, the median got down to 30 in this trial. And on the right, either the 5-part or the 3-part cardiac event endpoint was reduced significantly over a short time. These are the rates at 3 years with addition of the PCSK9 inhibitor. Now, one of the questions has been, well, how low should we go? And so they did an analysis where they looked at the achieved LDL, and this graph looks exactly like that other graph of all the different trials. These are adjusted event rates, so trying to control for differences in the patients. But you can see that the lower event rate goes all the way down to 0. So you can get the LDL down to single digits, and those are the patients who have the fewest heart attack, strokes, or death. And so a really nice demonstration that there's no limit to how much benefit one gets. Now, the other question that comes up is, well, what about side effects? Is it safe to get an LDL? And I have someone reach out to me today with an LDL of 17 and said, oh, should I back off in the different meds that he's taking? And answer, no. And this analysis looked, the different colors are the different achieved LDL level early, and then the subsequent risk of the different events. So any serious adverse event or new onset diabetes or cancer or changes in liver function tests, et cetera, none of those things differed based on how low the LDL got. And so you get the benefit that we just looked at of fewer cardiac events and no increase in any of the potential side effects. So affirmation that lower is better. Now the last class of drugs that's approved and in the ESC guidelines just added in is bempedoic acid. And this is an agent that doesn't impact muscles in any way. It has a mechanism of action somewhat similar, just one step above the statin effect, but it doesn't get into muscle, so it has no impact on muscle aches. And in this large trial of patients who had had problems with statins in the past, they got about a 20% reduction in LDL. Over time, people started in the placebo arm adding other agents. It also, interestingly, does reduce C-reactive protein, as do statins and ezetimibe. And then, more importantly, it reduces clinical events. So either the 4-component or 3-component major adverse cardiac events are significantly reduced when adding the bempedoic acid. And so a nice other evidence-based tool that we can use to try and get the LDL down. And so this is a graphic that plotted out the various different trials and has the baseline and the achieved LDL. And you can see that each trial we do, we keep pushing the LDL lower and lower. We just looked at the Fourier trial that took it down to 30. But we can see here the old target used to be, after the Prove It trial, to be less than 70. But the 4 subsequent big trials all pushed to less than 55. And so that's where the ESC guidelines said less than 55 for the very high risk ASCVD patient. Now, the other question that old guidelines had wondered about is, well, what about in clinical practice? Each trial adds a new agent or uses different doses of different agents, but what about actually testing the strategy of treating to a target? And so this group of investigators did this in patients who had had a stroke, that they treated to the old target of less than 100 versus the new target, at the time of less than 70. And so here they started with statin, increased the dose if needed, and intensity, added ezetimibe, an add-on therapy. So the strategy of aiming for less than 100 versus less than 70, you can see on the left, they achieved that beautifully. And on the right, you can see that led to the same benefit we saw in all the other trials of a clinical reduction in events. This reaffirms the notion that how we practice in clinical practice of starting, adjusting the statin dose, adding other agents, that strategy is a proven strategy. Now, new things are coming. And so one of them is an oral PCSK9 inhibitor. And this is one of the phase 2 studies, I think phase 2, this particular study, but has been reaffirmed in other larger LDL-based trials, that you get about a 60% reduction with a once-a-day dosing of this oral PCSK9 inhibitor. So very similar to the injectable ones that are currently available. So this could be yet another tool to get a big effect on LDL. And future trials are ongoing, also looking at clinical events with this agent. The other class of drugs we'd seen on my other slides, the CETP inhibitor, there's one agent called obicetrapib that has the LDL effects shown here, about 40% of this study. Others, can be, between 30 and 40% reduction in LDL. And they have an outcomes trial that's ongoing that will look to see whether adding that agent could be lead to a benefit on major adverse cardiac events. So yet another potential tool. We know that this class works with a drug called anacetrapib that reduced LDL and reduced clinical events. So, lots of new tools coming that can help get to goal. So this is a registry that we did to say, with all the stuff going on, new guidelines came out in 2018 towards the end of the year. Are we doing better? And so we studied 5,000 patients who were not at goal, and tracked over the next 2 years what treatments were the doctors and their caregivers giving. And so, unfortunately, we saw very, very slight improvement in care. So the overall use of statin went up by 1 point. High intensity statin went up by 5 or so points over time. Use of ezetimibe, 3 to 5% more people got ezetimibe, and about 4 to 5% more, or 4% more got PCSK9 inhibitors over this 2-year period. Overall, only 17% of people had new intensification of their treatment. So kind of disappointing, and like, why don't we embrace this proven therapy where we have lots of different options? And so that's a question that we ask ourselves, and these were a few thoughts that I gathered to try and understand, why don't we follow our own guidelines? One of them, unfortunately, I think in 2013, to great fanfare at the time, there was all the statin data on intensive statin therapy that they said, oh, we don't have evidence for treat to goal, and we shouldn't have an LDL goal. We should just treat with the evidence-based thing. So it led to confusion. They've subsequently changed that in 2018 to, adding therapies, as we saw, if you don't reach a certain goal. But that unfortunately set the field back, I think, a good bit, that introduced confusion, where before we were just titrating to the LDL goal. I think fortunately now we're getting back to that. The European guidelines always kept the LDL goals and said, match them to the patient's risk. A second thing that I've seen is that despite all these different agents, there's a lot of awareness about statins, but less so amongst clinicians or patients, to that matter, of the non-statin agents. Generally, there's clinical inertia. In part, we only see patients if they're stable once a year, and in cardiology anyway, and maybe twice a year for primary care. But if patients are doing well, we don't necessarily change things, even though it might help further. System issues of lack of time and not having enough follow-up visits and things can be a factor. Then I think we all know of some patient reluctance. Everyone's heard of muscle aches with statins, and generally not wanting to take medications is reasonable desire. But if you have disease or have high risk, we don't want to avoid things that could be helpful. So getting over that, and I think that's where the education I've found has been very helpful, of showing them the picture of the arteries and what we're trying to do. This has been amplified by all kinds of stuff on the internet of people with agendas that say that the sky is green and water is blue, or I guess water is blue, but water is red, and who knows? There's all kinds of misinformation that, oh, cholesterol is not proven, it's all just a hoax. So that's not helpful. And then more in the primary prevention question of people will say, well, do I really need to take that? And so one area there that's been helpful, I think, is actually looking at individual patients' arteries to identify whether or not they have atherosclerosis, and then the certainty of the need is more clear. And then finally, the cost of new therapies is, of course, a barrier, but we do have several, older therapies that are less expensive. So I'll walk through a few of these. I think, the ESC, as I noted, have kept the LDL goals, and this is very straightforward, very logical, very evidence-based, that the higher your risk, the lower we want to get the LDL to get that benefit. Nicely, the ACC-AHA did make a step in this direction by reintroducing the LDL goal and the less than 55 goal in patients who have recently had an acute coronary syndrome. where they say adding a non-statin agent if your LDL is above 70 to try and get below 55. So that's a good step in the highest risk population, and we'll see next year how that plays out in the overall lipid guideline. Another thing could speak to the system issues, and this was something that several colleagues developed. I played a small part in it, where there was remote management, where we had a whole team who could call up patients, check with their LDL and their risk profile, and work with a pharmacist to prescribe, and have digital technology to, do cross checks on, drug-drug interactions and what should their LDL goal be. So a different mechanism that could supplement the annual visit with the cardiologist to say, oh, actually your LDL has drifted up, we need to, intensify your treatment. And so for patients who were able to follow the program, we had about a 50% lowering of LDL shown on the right. And overall, it was about 35%. Some of the people didn't always follow through. So this is an adjunct, a system approach that could help overall. As I noted, everyone's aware of the side effects, and so having a nice step-by-step approach for patients who have statin intolerance, I think, is helpful. And it starts with really a discussion and shared decision-making with the patient. And so making this their understanding, and I, showed these diagrams with the patient, talk through what it is that we're worried about so that they understand. And then if patients have had issues with statins, say, okay, well, let's do a holiday and hold the thing, see if your symptoms go away, and then do a re-challenge to see if they come back once you retake it. Because plenty of people, I certainly know I get muscle aches all the time, even though I don't take a statin. I thankfully don't need one. But, to sort out what are statin-related side effects versus just other, symptoms people have, then trying an ultra low dose of a statin, so like half of the smallest tablet of rosuvastatin 3 times a week is like 1/10 of the normal dose. Many patients are open to trying it, and you say, if you get your symptoms, we'll stop it and then move on to the non-statins, and we have plenty of them to try. But to really work through a program for each patient to do that. Now, the other big change in practice that I've seen and that I have adopted wholeheartedly in primary prevention is the use of the calcium score. And essentially, this is a low radiation CAT scan to look and see, is there evidence of calcified plaque in the coronary arteries? And this is used in 2 ways. It can identify patients who have nothing in their arteries, and those patients are at very low risk. I'll show you the slide in the next slide. Or if we identify disease, we can then enter in the discussion and say, well, you actually have cholesterol building up in your arteries, and you have a lot of cholesterol building up if the score is very high. And that makes it easier to then say, well, it's time to start getting that LDL down. The power of 0 is helpful, that if you do get a score of 0, meaning that there's no sign of a calcified plaque in your heart arteries, those bottom curves there in pink show that it's very low risk. All the way out to 12 years, it's like a 3% risk of heart attack, stroke, or death. And so what a strategy some people will do is, if you get a score of 0 and the patient doesn't want to start therapy, you don't really have to. You could defer and then retest after 5 years. Then if you see a little something building up, then you say, okay, now it's time. So that notion of really seeing in each patient, do they or don't they have atherosclerosis, is very helpful. Now, interestingly, one doesn't have to do a dedicated calcium score necessarily. A lot of people have already had CAT scans for various reasons. And if you see coronary calcification, or indeed abdominal artery calcification, then you know that they have disease, and we want to try and get the LDL below 70 or ideally below 55. And so using the imaging really helps engender a very good discussion with each patient. So when do I do this? Often the patients who are younger in their 40s and 50s, that they have a family history of, multiple family members with heart attacks, but the calculated risk score will be low because their age is low. Those are ideal patients. I have a colleague I just did working with now, who's 41 years old, low risk score, but to do a calcium score, we'll see yes or no. Is there something there? And if yes, then you treat. If no, we can wait. Older patients with no risk factors. Also, that's one other group. Or the statin intolerant patient who you've tried 5 different things, and everything you try, they have, symptoms. I've then said, all right, let's just double check that we really need to. And if you get a score of 0, then you say, okay, we'll just let your LDL be high. You haven't been developing, atherosclerosis, so we don't have to. And then also patients who are really reluctant, with misinformation or just general want to avoid things, it helps them see their arteries and really can gauge overall what to do. So to summarize for lipid lowering 2025, I think across the risk categories, I didn't talk too much about the trials with primary prevention, but there the target is more around 100. And we start with statins, but then can use ezetimibe, bempedoic acid, could use PCSK9 inhibitors as well if needed. But then as I just went through, in the primary prevention group with low risk scores, using the calcium score can really shift the discussion to a clear one. For patients with known disease, we have the 4 different classes of drugs, and we start with the 2 ones that are generic and lower cost, and then move on to the other agents to target less than 70, or if you're higher risk, less than 55. We went through the statin intolerance. We use these ultra low dose regimens or all the different non-statins. And we fortunately have lots more coming. So new ACC/AHA guidelines are coming, and then new agents of oral agents that are more potent LDL lowering agents that could help us get to these goals. So with that, I want to thank you very much for your attention.
Thank you so much, Professor Cannon, for an incredible piece of education. We've got some time for questions and answers, but before we dive in, I'm just going to pull up the QR code on the screen so that if you don't have time to stay for questions and answers, you can at least claim your CME certificate, because that's important. So please give that a scan, give us some feedback, and you'll be able to claim your certificate. I'll pop the link for it into the chat box as well. Okay, we have some fantastic questions coming in across all of our channels. Prof. Cannon, thank you so much for joining us and for such a great piece of education.
Sure, a delight to join.
I'm going to dive right in if that's okay, because we have lots to get through, and we've got some fantastic questions from our audience. I'm going to start with a question from Rosella, which is this. Do you recommend pre-diabetics with 0 calcium scoring start low or moderate statins?
It's an important balance of, risk and benefit. The calcium score is a pretty potent tool to say that those patients are low risk, that there's nothing seemingly in the arteries. Nuances of that are that there can be some people with non-calcified plaque that would be able to be picked up with a more detailed scan, so a CT coronary angiogram. Those are more expensive, more radiation, more of a, takes more time. So if you're a little, unsure, especially if you're younger than 40, the calcium score often is less reliable in that you don't, if it's 0, you can't be sure that there aren't plaques that haven't yet calcified because it's so new. Sometimes what I'll do is carotid ultrasound as a second area to look and see, is there any sign of atherosclerosis? In the pre-diabetic patient, in theory, they're at higher risk. In general, a little bit lower risk than we originally thought. When you look at how just pure pre-diabetes, not with diabetes, what is their cardiac risk? It's not that different than people based on whatever other risk factors they have. But those are the people at most risk of moving faster to diabetes with statins. Now, it's just a 10% higher chance with the standard dose statin and 35 or so percent with high dose statin. So they're at more risk of the side effects. And given the calcium score of 0, they're doing pretty well on the arteries. So I wouldn't rush to do that. And one could consider ezetimibe as a single strategy, but depends on what their LDL is. If it's sky high, then like to get it down. Often it's more modest in patients with pre-diabetes or diabetes. So a long answer is meaning that it's complicated, and you really have to balance the different factors on both the efficacy and the safety side.
Got another interesting question here about risk categorization. So the 2025 ESC guidelines introduce an extreme risk category for patients with ASCVD and recurrent events on maximally tolerated statin therapy, setting an LDL-C goal of less than 40. Could you elaborate on the specific clinical evidence, perhaps beyond the current trial data showing benefit down to single-digit LDL-C that strongly supports pushing to that very aggressive goal, particularly for polyvascular disease patients? Interesting question.
Yeah, and I was going to say that in addition to that, you listed the polyvascular group. So if you have evidence of a prior MI and, carotid disease, et cetera, or peripheral arterial disease, those we know are super high risk patients. And so I think the analyses are the subgroups within the two PCSK9 trials where the benefit is seen, and the LDLs that were achieved in Fourier was about 30, and in Odyssey Outcomes was about 40 over the time. And so those are the two trials that pushed, and the people at the extreme risk had bigger absolute benefit because they're at such high risk that they really benefit. So good evidence for that. And, the evidence of there being extreme risk has been decades of, the polyvascular patient and recurrent events, many, many studies showing the risk and those more recent trials showing the benefit. So it also makes total sense. And it's a continuum of the rest of that risk line, really, that the higher the risk, the more intensive the treatment. So that general paradigm is something we do across all of medicine, but is a very evidence-based one here in lipid management.
We've had a few questions coming in around coronary artery calcium scoring. So perhaps I can combine a few of these into one. For a primary prevention patient with a low ASCVD risk score, but a family history of premature coronary artery disease, a coronary artery calcium score of 0 is a strong negative risk marker, suggesting statin therapy can be safely delayed. How do you handle a patient in this group who subsequently presents with an elevated lipoprotein A? Does a 0 coronary artery calcium truly trump a markedly elevated lipoprotein A in the decision to withhold statin therapy?
Yeah, so excellent. I think I had two of exactly this patient in the office this past week, and so as we're testing for Lp little a more, we'll find them. But that again is a risk factor. So we measure it in the blood. If the Lp little a is only in the blood, it's not causing any trouble. If it starts to create plaque, then it can start to cause trouble. And so that both the LDL and the Lp little a are really two kinds of bad cholesterol that can make the plaques worse. So those would be a patient where I'd probably do the carotid scan, sometimes I've done the full CT coronary angiogram to be doubly sure because they have a double risk factor of high LDL and high LP little a. So really to try and be sure, and I think one of the two I might have actually ordered that this past week. More risk assessment, I suppose, as you find the LP little a. Now, the flip side of that is it's never wrong to have a low LDL. There are the potentials for side effects, but, we monitor for those. And so if one wants to say, look, I've got pristine arteries, I want to keep them that way, and I want my LDL down, terrific. And with the high LP little a, that for the moment we can't influence that much. So, that could be a good reason to get the LDL down as low as possible to sort of counterbalance that. So it's very reasonable, but this shared decision making that some patients want to take things. I just hung up the phone with a guy who's taking 3 lipid-lowering. He said, look, doc, I want to stop all this. So different people want to, have different approaches. And so working with them to help them understand the balance and then make the decision for themselves. Um,
And we've got some questions on some of the emerging therapies you talked about. So the Clear Outcomes trial demonstrated a 30% reduction in cardiovascular events with bempedoic acid and no impact on muscles, making it a valuable tool for statin intolerant patients. In clinical practice, how do you position bempedoic acid versus ezetimibe? Is bempedoic acid typically reserved for patients who fail or cannot tolerate ezetimibe, or does its unique mechanism of action and demonstrated outcomes support its use as the preferred initial non-statin agent in certain high-risk statin-intolerant populations?
Yeah, these are quite thoughtful and detailed questions here. So I think the big difference is cost. So ezetimibe's generic and low cost, bempedoic acid is new and often covered by insurance. So that puts ezetimibe first. It also has many trials showing the benefit on clinical events, and both studies, so we did it first in Improve It, and they did a similar analysis in Clear Outcomes to see that the amount of clinical benefit relates exactly to the amount of LDL lowering. And that's been helpful conceptually across all the different agents to say it's the LDL, that's the most important thing. And how much it comes down is how much benefit you would expect, regardless of the agent. And so, wouldn't be a preferred thing to do bempedoic acid first, necessarily. And so one uses the generic therapies first and then moves on to the others. Um, but we simply add them, and this can be for statin intolerant or for anybody, that it's another tool to use. Often the decision of people who are on statin, or if they can't tolerate statin, and then they're on their ezetimibe and their LDL is still too high, what do we choose next of bempedoic acid or PCSK9 inhibitor? And their pill versus injection is a dominant factor, but also 20% lowering versus 60% lowering. It depends how far off the goal you are as to which one you choose. So there wouldn't be a preference, but it's in the mix. It's evidence-based, proven. It's nice to know that it was tested in 14,000, I think, statin intolerant patients. So if it is a statin intolerant patient, there are 14,000 patients just like you where this was tested and didn't have those side effects. It does have one or two others. We have to check the liver enzymes and renal function can sometimes worsen with bempedoic acid. And I've been avoiding it in gout, although some people will use it and monitor carefully because it can make uric acid go up and worsen gout. So ezetimibe really didn't have any difference in side effects on anything. Liver enzymes went up about 1% more. So you always want to check liver enzymes a month or so after starting ezetimibe. So the nice thing is we've got lots of options for the non-statins, and to have those, we often need them to get people to goal. And so more often than not, people are on both ezetimibe and bempedoic acid in order to get to goals, especially as we keep pushing the goals lower and lower.
Um, a shorter question. This one's from Haley, which is this: does ezetimibe have MACE data?
Yes, so the first trial that we did to show that was called Improve It, where we studied patients who initially had an acute coronary syndrome, all were on a statin. We got the LDL to below 70 on average. We used simvastatin in that study, and then half the people had ezetimibe, and it had a significant reduction in clinical events over the next 6 years. It was a median of 6-year follow-up. Um, for some reason, the FDA decided this was the first of the non-statin trials that they, the p-value is 0.016, and somehow they didn't think that was low enough. So they didn't grant the indication for cardiovascular event reduction, um, but every guideline has. The next trial was in primary prevention, called the Utopia 75 trial. So very interesting. It was done only in elderly, so above 75, where people say, oh, we don't need to bother. Primary prevention, and it was ezetimibe alone, so without statin, and that showed, I think, a 30% or so reduction in cardiac events, significant. Um, uh, and then two other trials explored the strategy of low-dose statin and ezetimibe in place of higher dose statin or titrated statin. The racing trial was one and Lodestar was the other. And so those were designed to show equivalence of using lower dose statin and ezetimibe to get the same amount of LDL lowering as high intensity statin. They had similar outcomes. And so a total of 4 large trials with ezetimibe that showed the clinical benefits. And hence it's in all the guidelines.
That is us at time. We have had a really great hour of education, and we're really grateful to you, Professor Cannon, for joining us to share some of the amazing work that's going on in this space, but also for taking so many questions. So thank you so much for your time.
Well, certainly it's a delight and a great time in the field. So much happening, much to come. So you'll have to do another one next year because there'll be new things that have come along.
Sounds good. We'll have you back. Um, for those of you who are joining us, it's really important that you get credit for attending today. I'm going to bring up the QR code on your screens. Please give that a scan. I'll pop the link into the chat box, and that will allow you to give us some feedback, to also claim your CME CE certificate. It's completely free. You don't need to pay for it. It will be landing on your medal account instantly after completing that short evaluation. I hope you find today's session really useful for your practice. It's certainly been a pleasure to have you here and to host you. And I hope that we'll see you at another medal session sometime soon. Thank you so much for joining us.